Moving on to the next topic, would like to invite the chairperson, Dr. Shanmuga Velu, who is the physician from Trichy, Tamil Nadu. We welcome you on stage, doctor.
Thank you very much for a kind invitation. I don't want to take more time in introducing the topic. It's my unique privilege, happiness, and honor to introduce my friend, Dr. Balaji Chidambaram, who is a founder secretary, Metabolic Club of Kumbakonam, past treasurer, RSS Data Knowledge Chapter, fellow of RSS DI, International Diabetes Federation, as well as Diabetes India, to take all of us through his presentation on adherence in real world, tools for the cardiometabolic care. Over to you, Dr. Balaji.
Thank you, sir. Thanks for the great words of introduction. My sincere thanks and regards to my mentor, Shanmuga, sir. And at the outset, my sincere thanks to my close friend, LSM, for giving me yet another opportunity to be back at this garden city of Bangalore for ILET 2026. So, over the next 15 to 18 minutes, my talk will be on adherence care in what are the tools in cardiometabolic care. So, let me start what really adherence is. So, we all... Slides, please share the slides. No. So, we all have many number of patients with Yes. This is a little bit of. Yeah. The last one, yes. Okay, fine. So, thank you. So let me start with the real world things, what we face in your day-to-day practice. So we have many patients like this patient who walks into our clinic who is been on diabetes and hypertension, whose initial reports looks encouraging. So with a regular treatment, HbA1c is under control, blood pressure under control, and his parameters are acceptable limits till a certain period. But when he walks to our clinic, after some times, the picture is completely different. The HbA1c increases again, the blood pressure, it's not under control, and his kidney function slowly shows some decline. So these are the things what we have in our day-to-day practice. When we see the prescription, it's absolutely appropriate. Having a metformin, SGLT2 inhibitor, ACE inhibitor, and a statin. Everything is based on the evidence-based therapy and also exactly what the guidelines recommend. So naturally, we ask the question whether you are taking the medications regularly. If you just ask the patient, he says, most days I do, but sometimes I forgot and sometimes I stop for a few days when I feel I'm completely all right. So this is not a rare story. In fact, this is the real world story of cardiometabolic care, what we physicians experience in a day-to-day practice. So despite having effective therapies, we often struggle to achieve optimal outcomes. And these are the things which makes the patients, because they consistently follow them. So this brings us to one of the most important yet underestimated challenges in medicine's adherence. So the growing cardiometabolic burden, we all know that globally the prevalence of diabetes, hypertension, obesity, and chronic kidney disease continues to rise at an alarming rate. So India is experiencing a particularly rapid epidemiological transition, but they come with the clusters of interconnected disease. So these conditions interact with each other, often creating what we now call as cardiometabolic burden. Yet in real-world clinical practice, the outcomes often fall short of what the clinical trials promise. So one of the most important reasons behind this gap is poor adherence to long-term therapy. So the chronic or the cardio-renal metabolic system are interrelated. Heart is the most metabolically demanding organ where it is susceptible to changes in volume and metabolism. Regulation of energy metabolism by liver, pancreas, and fat is essential for healthy function of organs, and the kidneys play a key key role in glucose and volume hemostasis. So these are the things. Diabetes and other comorbidities, what happens? Oxidative stress, inflammation, endothelial dysfunction, glucohepatite toxicity, hemodynamic changes, everything happens around the body. So the burden of CV disease is very high. 28% of cardiovascular, 15% of nephropathy, and everything. So this is a growing cardiometabolic burden. So each and every day it increases in a rapid phase. So where is the missing link? Adherence. The most effective therapy fails without adherence. So 30 to 50% of the patients discontinue medications within 1 year. So non-adherence contributes to poor glycemic control, uncontrolled blood pressure, increased cardiovascular events, and higher hospitalization rates. So adherence is therefore one of the most important modifiable determinants of outcomes. So what is the adherence gap? See, if you just see the clinical trials where we have strict monitoring, motivated patients, free medications, and frequent reminders, but in real world practice, there has been a limited follow-up, variable motivation, the cost has been the issues, and forgetfulness, which has been the most common thing what the patients experience. Hence, efficacy is always not equal to effectiveness without the perfect adherence. So what is the adherence pathway? So successful medication adherence requires thorough assessment, better identification, individualized interventions, and patient engagement. So first, we need to access. So use a validated tool to screen the patients. Secondly, we have to understand. So identify the patient-specific barriers to medication adherence. Thirdly, intervention. So implement the individualized strategies to minimize the medication non-adherence. And lastly, shared decision making. So engage with the patients with and set the shared goals. So what does WHO defines? So the extent to which a person's behavior corresponds with agreed recommendations from an healthcare provider. So they include taking medications correctly, lifestyle changes, follow-up visits, and monitoring. So what are the dimensions of non-adherence? So 5 major factors: patient-related, therapy-related, disease-related, healthcare system factors, and socio-economic factors. So all 5 often coexist. So these are the barriers of patient medication adherence. So patient-specific barriers, illness-specific, medication-specific, healthcare system-specific barriers, social and culture-specific barriers, and lastly, the logistical and financial barriers. So let me just throw some things on the various barriers. Patient-related barriers: forgetfulness, lack of symptoms, fear of side effects, poor disease understanding, polypharmacy fatigue. Patients often stop medication because they feel better, not realizing the disease is silent. Secondly, therapy-related. So treatment complexity strongly affects adherence. Examples: multiple daily dosing, large pill burden, adverse effects, longer duration of therapy, and studies shows simplifying things, whereas in real things what we access is completely different. So what are the disease-related challenges? So cardiometabolic diseases are chronic and largely asymptomatic. We know about hypertension, which has been a silent killer, CKD, dyslipidemia, often asymptomatic. So what is a consequence of poor adherence? So poor adherence leads to poor glycemic control, which leads to uncontrolled high blood pressure, which progresses to CKD, which finally ends in increased cardiovascular events, which has been the highest determinant for mortality rate. So where is the role for the patients, or what is the physician's role? So we play a crucial role in improving the adherence. So what are the key strategies? So clear communication, simplify the treatment, patient education, regular follow-up, shared decision making. So adherence improves when the patient understands the why behind therapy. So we should clarify the purpose of medicine, encourage to read the drug labels, educate on the adverse effects, help in generic drug selection, and finally follow up and address concerns. So these are the tips for medication safety. Write it clearly, report the side effects, store properly, set a routine things, build in reminders, stick with a schedule, organize, use a single pharmacy, and follow up and share the concerns. So, let me come to the last part of my talk. What are the tools to improve the adherence? So, therapeutic patient education is the most important thing. Secondly, simplifying the treatment regimes. Thirdly, maximizing the placebo effects and minimizing the placebo effects. Next, minimizing the treatment cost and early follow-up visits and short treatment goals. Lastly, reminder programs. So, let me start with patient education. So, education always improves adherence significantly. So, patients should understand the nature of the disease, long-term risk, importance of continuous therapy and lifelong things, lifestyle modification, visual aids, and simple explanation improve the retention. So, for just an example, if you just address the patient-related barriers with respect to GLP agonist use by eliciting or elaborating the fear of injections and fear of pain, it helps the patient to make the connection between doing something that is perceived as unpleasant and the goals they want to attain, including a greater sense of well-being. So, this is an example how to educate the person and improve the adherence. Secondly, the second tool, simplifying the treatment. One of the most effective strategies. So, once daily dosing, fixed dose combinations, reduced pill burden. So, where is the evidence? Study shows simplified regimens improve the adherence by more than 20 to 30%. Thirdly, the third tool, fixed dose combinations. So, FDCs are particularly valuable in cardiometabolic disease. So, what are the benefits? Reduced pill burden, improved convenience, better compliance, improved clinical outcomes. So, we have all amount of fixed drug combinations in our day-to-day practice. Fourth, the digital health. So, technology is transforming the adherence. So, we have many medication reminder apps, smart meal boxes, SMS reminders, and WhatsApp and other telemedicine follow-ups and digital tools helps the patient to stay connected with the treatment plan. Lastly, the behavioral strategies. So, we need to have a motivational one-to-one interviewing. So, set the goals with the patients, just implement on the reinforcement strategies, always involve the family. So, these are the things how to engage the patients emotionally, which will certainly improve the long-term adherence. So, to have all these things, we need a multidisciplinary approach. So, optimal adherence requires teamwork. So, involving the physicians, the nurses, the pharmacists, dietitians, and not the least, the family members. Your team-based approach significantly improves the adherence outcomes. So, for every 100 prescriptions written, if you just see 50 to 70% are filled with at the pharmacy, 48 to 66% are picked up from the pharmacy, 25 to 30% are taken properly. Lastly, only 15 to 20% are refilled as prescribed. So, this is a real scenario what we face. So, what is a real world impact? If you have an improved adherence, it can definitely reduce the cardiovascular events, delay the CKD progression, improve the glycemic control, reduce the healthcare cost, improve the quality of life. So, adherence is as important as choosing a perfect drug. So, returning to the patient, what we say in day-to-day practice, if we have a perfect counseling about the simplified regimen, medication reminders, and the progression of the disease, we can have a better patient in our day-to-day practice. So, the difference was not a new drug, only the difference was adherence. So, what is the final interpretation? Cardiometabolic diseases require lifelong therapy. Non-adherence is common in real-world practice. Simplified therapy improves the adherence. Digital and behavioral tools support the persistent, and we physicians play a significant key role in patient engagement. So, adherence is a bridge between medical science and patient outcomes. In cardiometabolic care, effective drug exists, the evidence is strong, but success ultimately depends on whether patients continue the therapy in the real world practice. So, adherence has been the key to better outcomes. So, each and every missed dose is a missed opportunity and a measurable increase in the risk. So, to conclude, as Hippocrates wisely said, healing is a matter of time, but it is sometimes also a matter of opportunity. And in today's cardiometabolic care, that opportunity lies not just in prescribing the right therapy, but it is there in ensuring whether it is being taken, trusted, and sustained. So, in real world practice, outcomes are not limited by evidence, but by execution, and not by innovation, but only by implementation. So, right drug is science, right adherence is success. From prescription to persistence, adherence is the true bridge to outcomes. Thank you all for a patient hearing.
Thank you, Dr. Balaji, for your excellent presentation with reference to a clinical scenario and how you have approached and how you got convinced that adherence is very important in our routine clinical practice. So similarly, I have one patient. The patient A1C moved from 7.1 to 9.7 over a period of 6 months to 9 months. She was adherent. She takes medicine regularly, injections, everything. I asked the son as well as the patient to bring all the medicines. The thing is, the medicines were substituted. So whatever I prescribed, only the equal brands, that is chemically equivalent but not quality-wise. Please look into whatever prescription you are giving, see that it is not being substituted, because you know fully well what a quality brand is. That is very important. Second important thing is adherence, not only with reference to patient, but also practicing doctors. Doctors should also get adherent to the guideline-directed medical therapy, our own guidelines, APA guidelines, RSSDA guidelines, CSA guidelines, Indian Society of Hypertension guidelines, Lipid Association of India guidelines. So we should always insist our doctor friends to read all the guidelines and see that they are adherent to the treatment part of it. That's my humble suggestions. Thank you, Balaji.
Thank you.
Any questions from the floor? Thank you very much. I thank the organizing committee for giving me valuable opportunity.
Thank you, doctors. We request the speaker and chairperson to move towards the selfie area, which is right outside the hall.